name's Jameson. I'm a surgical outlier. So in January 2023, I received an email from the NGR and said that we're writing to let you know the latest review of data for primary knee replacements. It has a higher than expected revision rate. And at this point, it indicates an alarm status. So what does that mean? Well, we've seen the film plots already this morning. We want, once standardised revision rates are calculated, we want to be within the 95% confidence intervals. If you stray over 95% or 2 standard deviations from the mean, you get an alert, an outlier letter, and if you go above the 3 standard deviations or 8% confidence interval, you get the alarm. So this was my data. I've been straddling the 95% following a few revisions early on in my career and wasn't really shaping it off. And then last year I had a few more revisions and we ended there. So we've discussed this before, but there is some adjustment that's not made in the data. It's very difficult to obviously adjust this within the NGR, but obviously there is complexity involved that may or may not have an impact. But why am I an outlier? Well, is it that I'm a bad surgeon? Am I simply poor technically? Am I making poor decisions? Or is it that actually I'm a really, really good surgeon? It's something else that's causing all these problems. It's got nothing to do with it. Could it be the implant that I'm using? The hospitals I'm working at, the processes there. Could it be my patients? And could it be those pesky revision surgeons who are revising on my needs unnecessarily? Well, probably, in actual fact, it's a combination of all these factors. So what should you do? Well, don't panic and certainly don't ignore it. You must acknowledge that you have been identified as an outlier. You must inform your medical director. The NGR will as well, but it's a good idea to write them an email just explaining things. You should speak to your CD and you should speak to your orthopaedic lead. That was the easy one because that was me at the time. However, there should not be a surprise, and the reason is you should be all looking at your NGR data through NGR Connect. You should be reviewing the data regularly. You are advised to use it for appraisal and for orthopaedic governance, and you will get emails whenever one of your primary hip or knees has an adjustable revision or has died within 90 days. And you need to check the accuracy of these because sometimes this is not always correct. The data has been misfiled on the data set. So we annually look at our clinician feedback data openly in our orthoplastic governance meeting. This was the data that we looked at for me in September 2022, so that's 6 months before the alarm. And we knew that I was struggling the 95% confidence limit. I had made a few changes to my practice and everything seemed okay. This is a timeline of what my data has looked like since I started as a consultant, so I've been a consultant for 8 years. This is the cumulative primary knee replacements that I've done over time. You can see that initially I started off doing quite a lot of knees, and then that started to tail off. COVID's the kind of flat bit in the middle. My revisions are at these points. Obviously revisions occur at all the different times after the original primary surgery, but when you get a clustering, together with a flattening of the primary knees that are going in, primary joints that are going in, then I think that has impacted to a certain degree on my initial alert email. And then I think that, again, a contributing factor was a cluster of revisions, again, with a slight flattening of the number of joints that I was doing after COVID. Yes, so my arthroplasty practice is predominantly hips. I do 75% hips. I do revisions. I used to do knee revisions as well. This is the data that is the last available data on NGR Connect before my alert. You can see that my knee primaries, decent numbers at the beginning, but that tailed off towards COVID, and then it's not really recovered up until last year. The thing to say is I don't do any work outside the trust, so certainly in our area, a lot of the more straightforward knee replacements may be going out into the community to independent hospitals. That may have an impact as well. The next thing is, what implant am I using? Well, I'm not using anything crazy. I'm using an 15A star rated implant. I use it in a fairly standard fashion. I selectively, or at least certainly before I changed my practice a little bit, I selectively resurfaced, and I think my technique was a fairly standard technique. I did some complex primaries, and did some mini revisions, although not 15 per year, and I wasn't doing any unicondylas. My problems data, which we analysed, was pretty good. It's comparable, or maybe slightly better than the national average. So what did I do? I did a case review of all the revisions that were under my name. I created a slideshow, and I sought peer review from one of my senior knee replacement surgeon colleagues, and also an external surgeon. And I went through the slideshow, and I created an action plan. The action plan was then cascaded to the NGR and to my medical director, my CD, and to my orthoplastic group. And bear in mind that all this is very open, lots of discussion within my orthoplastic group about what the plan was, what I should be doing. And many of my colleagues, in actual fact, said it's totally stupid, don't stop doing revisions, don't do this, don't change, because they felt that there was no particular issues. Reflection, lots of self-doubt. It was certainly a stressful time. It was frustrating because I think that I've kind of definitely prided myself in trying to do a good job. It was definitely emotional, and it was definitely time-consuming. And bear in mind all the things that have gone in your life, and a busy practice as well. It makes it quite difficult. But good things. It was very useful. It forced me to review my practice. It made me change my practice and focus on improvements. So I would urge you all to protect your practice, especially the more junior surgeons or the newer consultants, and make sure that your patient selection is good. Think about things like BMI and the stage of disease. Don't do someone too early in disease. Don't wait too long, or if it is very, very difficult, seek help. Dual operating is very useful. Look at the units that you're working in. You may be working in independent sector hospitals as well as your local trust. Our local trust has excellent infection rates. One of our local units has slightly higher infection rates, and it's really affecting one of my colleagues who does that work in the independent sector. Implant selection, look at ODEC ratings, know your NGR data, know that there are thousands and thousands of different ways you can do a knee replacement within one brand, and try to make sure that your brand and your component sets are correct. We've touched on metal before, but that could be an issue obviously before my time. And obviously there are implants that have been pulled off the market all the time. Use tried and tested implants, and regularly access your consultant level data and reports, and use no crazy. Do you discuss your clinician feedback reports annually in arthroplastic governance meetings? Review your proms. It's really useful to have a look at that, because even in the darkest days when my revision rates being too high, I was comforted by the fact that at least the patients that haven't been revised seem to be doing all right. Discuss complex cases in the MDT. We've got a very mature MDT. We discuss all of our complex primaries and obviously the revision cases. Consider simplifying your practice and ensure you do adequate numbers. And then we focus on the things that perhaps have been highlighted in your peer review. And certainly one of the things that I have changed is my approach to resurfacing and taking on more complex cases, which I don't do now. And ensure all your department revisions are discussed at MDT prior to surgery. When we look back at some of this data, certainly I found that some revisions weren't passed through the MDT by my colleagues, and perhaps not worked as well as one would like. So in summary, be aware of all the data that you can get from the NGR and use it to your benefit. Use NGR Connect and use the clinician feedback reports. Do review your data with your colleagues annually. Use your local MDT to support decision making, and protect yourself with your implant choices and the units that you're working at. And if you become an outlier, don't panic. Review your data and review the accuracy of it. Formulate an action plan. Make timely response to the National Drug Registry. Support and peer review is really important. Discuss it, talk about it, don't hide it under the carpet, and use it as a positive experience. Thank you.